Hello and welcome. Thank you for joining us one more time in learning on different concepts of human physiology. Today we are going to learn how the kidney makes urine. We're going to concentrate on glomerular filtration, and other videos will show the other steps. So let's get started. These are the 3 steps of urine formation. Blood enters the kidney. It's going to go first through a process of filtration where substances will move from the blood into the Bowman's capsule. Reabsorption is bringing substances back from the tubules to the blood. Secretion is pulling substances from the blood back into the tubules. And finally, this is going to be excreted, totally eliminated out of the body as urine. So we're going to be talking about filtration. What is the definition of filtration? We're talking about removing substances from the blood, plasma from the blood, and moving it into this place which is called the capsular space. Now this is a very familiar type of filtration over here. What are we looking at? We are looking at a filter. This is fluid, and certain substances are going to pass through the filter and move with the water to one side. Certain substances will not be able to travel, will not be filtered. What determines this is actually the size of the pores in the filter. So where does filtration occur in the kidney? It occurs in a very specialized part of the nephron that is called the renal corpuscle. So we're going to look at the renal corpuscle in a little bit of detail. This is the renal corpuscle. This is where blood comes in through the nephron. This is a big arteriole called the afferent arteriole. This is going to branch into small capillaries, which we call the glomerulus, and blood will leave again through the efferent arteriole. The glomerulus is surrounded by a capsule called Bowman's capsule. So we are going to look at a little bit more detail of the renal corpuscle. This is the glomerulus. It makes the first part of the renal corpuscle. This is the capsule, Bowman's capsule, which surrounds the glomerulus. Any substances that are able to move out of the glomerulus and into this space, which is called the capsular space, is now filtered, and we call it the filtrate. It's no longer blood. It has been filtered through. So this is actually where filtration occurs. Now we need to pay attention to this membrane here, the filtration membrane. So we're going to make it a little bigger to learn the details. When we look at what surrounds the glomerular capillaries, we will find that there is a very special cell called the podocyte. Why do we call it podocyte? It's really a cell that has foot-like processes. And these podocytes will wrap around the glomerular capillary, and they will make one of the layers of the filtration membrane, which we will look at in a minute. So we're going to make this a little bigger, again, to make sure we know where are the different parts that make up the filtration membrane. So this is a very nice depiction of the podocytes. This is the glomerular capillary. The podocytes are surrounding it, they wrap around it. If we look closely at the endothelium of the capillary, it has small pores. We call these the fenestrations or the fenestra. So substances can move out of those pores. If we look at the podocyte, it has those foot-like processes, and there are spaces or gaps in between, and we call these the filtration slits. So the filtration slits is going to form the third layer of my filtration membrane. So right now we can see two. This is the first layer. The slits make up the second layer. The third layer is in between. So we're going to look again at another very nice picture that clearly shows what are the different components of the filtration membrane. We're starting by the endothelium of the capillary. It has the pores of the fenestra. We have the podocytes that have the slits. In between these two is a double layer of basal lamina. What are the basal lamina? They are a basement membrane that protects every cell. So the basement membrane of the endothelial capillary, the basement membrane of the podocyte, these two basement membranes will fuse together and make a very thin membrane. So now we have three layers that make up the filtration membrane: the fenestrated endothelium, the fused double basal lamina, and the filtration slits. So as a reminder, these are the three structures that make up the filtration membrane. Now, these will determine the size of the pores. Anything that is small enough to travel through these three layers is going to be filtered. Anything that is larger will remain in the blood. So now we discussed the filtration membrane, but what are the substances that can pass through, and what are substances that will be held back in the blood? These are larger than the filtration slits and the pores. So these substances have to remain in the blood. They will never leave the blood compartment. They will come in through the afferent arteriole, circulate in the capillaries, remain inside the blood, and leave via the efferent arteriole. What are these substances? They are large. Red blood cells, white blood cells, platelets, all the plasma proteins, they remain in the blood. What are the small substances that can actually be filtered? So they are moving from the blood into the capsular space. These are smaller: the water, glucose, amino acids, many electrolytes. We're talking sodium, potassium, chloride, calcium. We're going to talk about these later in great detail. And nitrogenous waste. Specifically, we're talking about urea, creatinine, and uric acid. Now let me remind you, these are wastes, which means we do not want them to remain in the blood. We actually want to take them out and lose them in the urine. And this is one of the main functions of glomerular filtration. Why do we call them nitrogenous? Where do they come from? They come from the simple metabolism of proteins, and in large quantities they are toxic, and we do not want to keep them in the blood. We have to remove them. All right, so far we know the definition of glomerular filtration. We know where it occurs. It occurs across the filtration membrane. We know what substances are being removed, but what actually is the force that pushes those substances out of the blood and into the capsular space? So now we're going to talk about pressures, and collectively we call these the filtration pressures. So they are the pressures that will work together to allow substance to be filtered from the blood into the capsular space. We will discuss three main pressures. One of them is going to enhance filtration. It wants to push the substances with the plasma into the capsular space. This is by far the most important pressure. We call this the glomerular blood hydrostatic pressure. It is right here inside the capillaries, And this pressure is a representation of a person's blood pressure. It is actually determined by the blood pressure. So if a person has normal blood pressure, they will have normal blood hydrostatic pressure, and it will push the substances out and filtration will occur. If a person has low blood pressure, this pressure is going to be lower and filtration will not be adequate. So this is the main force that is enhancing filtration. The other two pressures oppose filtration. We're going to see where they are. We're going to look right here inside the capillaries. We have what is called the blood colloid osmotic pressure. Where does it come from? It is created by the proteins in the plasma. Those plasma proteins like to pull on the water and keep it in, so they are opposing filtration. The other force that opposes filtration is the capsular hydrostatic pressure. It's the volume of fluid that has been filtered here. It builds up into a certain pressure, and again it wants to push the fluid in the opposite direction, and it will oppose filtration. So finally, we can calculate what we call the net filtration pressure. How do these three pressures work together? We are going to add the two pressures that are opposing the filtration. So we're going to add the blood colloid osmotic pressure plus the capsular hydrostatic pressure. These two pressures oppose filtration. We're going to add these, and we're going to subtract them from the glomerular blood hydrostatic pressure, which wants to do filtration. We have the numbers, and eventually the net filtration pressure is about 10 millimeters mercury, which means filtration will occur, because we can see the glomerular blood hydrostatic pressure is still 10 millimeters mercury higher than those two opposing forces. All right. So now we know what is going to be happening in the kidney. Filtration will occur. How much fluid is filtered? Is there a number? Yes, there is. So we come to our next number here, which is the glomerular filtration rate. What is the glomerular filtration rate? In other words, it is the rate by which the glomerulus is filtering blood. It's around 125 ml per minute. And it is very important. The kidney wants to maintain this number all of the time. So the kidney is going to filter both kidneys, 125 ml per minute, day and night. When we're sleeping, when we're exercising, when we're walking, when we're eating, it wants to keep a regular, constant rate of filtration all the time. It's very important, and this number is a very important parameter of renal function. It tells me how efficient, how quick is the kidney removing substances from the blood, specifically the waste products. We want to maintain this rate all the time. We do not want toxic substances to remain in the blood. So it's a very, very vital part of the renal function. Now, the body will want to maintain this by different mechanisms, and we're going in a minute to discuss what are the different factors that are going to play a role in maintaining this normal glomerular filtration rate. But before doing this, we're going to zoom in on a very important area of the anatomy of the nephron, which will play a role. So we're going to discuss what we call the juxtaglomerular apparatus, or the juxtaglomerular complex. Where is this located? What does it do? So there are two parts that make up the juxtaglomerular apparatus or complex. We're going to start by the first one. It is in the afferent arteriole. When I look at the afferent arteriole, which is bringing blood to the glomerulus, it has very specialized cells. These are called the juxtaglomerular cells. What is the function of these cells? These cells secrete and store a very important chemical substance called renin, and we will see the function of renin in a few minutes. What else makes up my juxtaglomerular apparatus? We are looking here at the ascending limb of the loop of Henle. When I look at the ascending limb of the loop of Henle, as it comes very close to the afferent arteriole, there are very specialized cells that are called the macula densa cells. What is the function of the macula densa cells? These cells are checking the filtrate that is coming up into the tubules. Specifically, they are chemoreceptors for sodium chloride. They are checking the content of sodium chloride in the filtrate, the concentration of sodium chloride in the filtrate, and according to this concentration, if it increases or decreases, they have a function to do, which we'll learn in a minute. So again, to summarize and make sure we remember, the juxtaglomerular cell is made up of two components: the macula densa cells in the ascending limb of the loop of Henle. They are chemoreceptors for sodium chloride. The juxtaglomerular cells in the afferent arteriole are storing renin. So now, let's look at the different factors that affect the glomerular filtration rate. We're going to first look at intrinsic renal autoregulation. What do I mean by intrinsic and auto? It means the kidney itself is going to work on regulating the glomerular filtration. We have two of those. We're going to discuss the myogenic mechanism and then the tubuloglomerular feedback. Outside the kidney, we're going to look at some hormones that affect glomerular filtration, the RAA and the ANP. At the end, we're going to look at the nervous system having a role in glomerular filtration, specifically the effect of the sympathetic nervous system. So we're going to start with those first two. This is the autoregulation, myogenic mechanism. If I say myogenic, then we are looking at muscle. What muscle are we talking about? Who is responsible for this myogenic mechanism? Again, we are going to look at the wall of the afferent arteriole. This wall has smooth muscle cells. We know that smooth muscle can contract or relax. It can constrict and dilate. So the effect, the myogenic effect, is going to be due to those smooth muscle cells. It's very easy to understand. If these cells contract, if they vasoconstrict, there is less fluid reaching the glomerulus. This will decrease filtration. If these cells dilate, more fluid is coming to the glomerulus, and this will increase the glomerular filtration. So let's see how these cells will work. How does the myogenic mechanism actually works? If there is increased arterial blood pressure, I'm increasing the blood hydrostatic pressure. This will increase the flow into the afferent arteriole. This will stretch the afferent arteriole. As a reflex, once it's stretched, those smooth muscles are going to constrict. When they constrict, they are going to decrease the blood flow that's going through the afferent arteriole, bring it back to normal, so we come to back, we regain the normal glomerular filtration rate. Remember, vice versa, the opposite exactly will occur. If there is low blood pressure, we are going to reverse all of this process. We will have dilation of the afferent arteriole to increase the glomerular filtration rate. So these are very important for autoregulation, and they will minimize changes of in glomerular filtration with little fluctuation in blood pressure. A little increase or a little decrease, the myogenic mechanism will maintain the regular, constant flow of filtration. Another means of autoregulation is the tubuloglomerular feedback mechanism. Let's break this into two words to see what we mean here. We're saying there is a feedback from the tubules to the glomerulus. Who is doing this feedback? Now we are looking at the macula densa cells. Remember, what do the macula densa cells do? They are checking the content and the concentration of the sodium chloride in the filtrate inside here, and they are going to give signals to the glomerulus. How does this mechanism work? So this is how it works. If there is increased glomerular filtration, there is more filtrate reaching the loop of Henle. There is more sodium chloride detected by the macula densa. What are they going to do? They will secrete vasoconstrictor chemicals. These will constrict the afferent arteriole just a little, so as to decrease the blood flow and bring the glomerular filtration rate a little lower back to the normal. Again, the exact opposite will occur if there is decreased glomerular filtration. The feedback will be able to increase it back to the norm. So this is the first big component that we call the autoregulation that occurs by the kidney in the kidney. Next, we're going to talk about the effect of certain hormones. We're going to discuss the renin-angiotensin-aldosterone system, commonly known as the RAA system, and then we're going to talk about ANP, which is the atrial natriuretic peptide. Let's start by the RAA. How does this work? What is this stimulus? Now remember, the main primary function of the RAA system is to maintain normal blood pressure. It will be activated if the blood pressure drops. It's going to work very quickly to maintain and to bring the blood pressure back to normal. And its effect on glomerular filtration is a secondary function. So let's see how this is activated. It will all start if there is drop in the blood pressure or drop in the blood volume. If this occurs, there is less blood reaching the kidney right here because there is not enough blood. We call this decreased in the renal perfusion. If there is less renal perfusion, this will stimulate the juxtaglomerular cells to increase their secretion of renin. What does renin do? Renin is going to take us through several steps, and we're going to look at these very briefly. Renin converts a substance from the liver called angiotensinogen into angiotensin 1. Angiotensin 1 is converted by a substance from the lungs called ACE into angiotensin 2. Now, angiotensin 2 does the two effects that will raise the blood pressure back to normal first. Angiotensin 2 is the strongest vasoconstrictor substance in the body. So angiotensin 2 will vasoconstrict all of the systemic blood vessels, and we know vasoconstriction will raise the blood pressure. Angiotensin 2 also will go to the adrenal gland and stimulate it to produce the hormone aldosterone. We know aldosterone will reabsorb sodium back into the body reclaim it from the kidney. Once we reabsorb sodium, we reabsorb water with it. Water always follows sodium. Reabsorption of sodium and water will elevate the blood volume and increase the blood pressure back to normal. So these two functions will increase the blood pressure. We said blood pressure is the main effect, or it is the determinant of the blood hydrostatic pressure. Accordingly, secondarily, we increase the blood hydrostatic pressure and filtration increases. The second hormone we're going to talk about is ANP. And just to remind you, it starts with atrial. So who is producing ANP? ANP is released by the atria of the heart. When does the heart secrete ANP? This is the mechanism. When there is increased blood volume, increased blood pressure, there is stretch on the wall of the atria, and the atria will secrete ANP. So this is the mechanism. Increased blood volume and blood pressure will stretch the atria, and the atria will secrete ANP. What is the effect of the ANP? ANP is going to be carried from the atria, go to the kidneys, is going to go to the afferent arteriole, and this is what's it going to do. It's going to dilate the afferent arteriole, constrict the efferent a little. If we dilate the afferent, there's more flow, increased glomerular filtration. We are moving fluid out of the blood into the tubules. We are losing this fluid, and there is decreased blood volume and blood pressure back to the norm. Remember, we want to bring things always back to the normal. This is not the only effect of ANP. We're going to talk later on in another lecture. Really, one of the major effects of ANP is to get rid of sodium. But this is in a different context we're going to discuss later. Now, the third part is the neural regulation of glomerular filtration rates. So we're talking about the effects of the sympathetic nervous system. If you remember, the sympathetic fibers, the sympathetic nerves go to many different parts of the body, and when there is sympathetic stimulation, they are also going to go to the kidneys. What do they do? When the sympathetic nerves stimulate the kidney is going to produce renin, and we know renin is going to be converted into angiotensin II, and we know the effects. Now, depending on how much sympathetic stimulation, this will affect glomerular filtration. So, mild to moderate sympathetic stimulation. You went out for a nice little walk. Little exercise is going to stimulate the sympathetic nervous system. This will stimulate the kidney. A small amount of renin is produced, and so a small amount of angiotensin II is produced. This will increase the blood pressure, increase the glomerular filtration a little. However, a very different situation, emergency situations where there is severe and very strong stimulation of the sympathetic nervous system. If there is severe blood loss, hemorrhage, if there is severe dehydration, the sympathetic stimulation to the kidney is going to be much stronger. The level of renin is going to be more. There is more angiotensin II. Now, angiotensin II is going to vasoconstrict all the systemic blood vessels, prevent blood from going to the kidneys, to shift it, to keep it away, because I need the fluid now to remain in the vital organs, the blood and the brain, and this is how the body is going to deal with those emergency situations. We're done with the factors that affect the glomerular filtration, and we're almost done with this presentation, but I would be amiss if I would not end this with some clinical application, just to bring this into focus, how the body reacts in pathological situations. So I chose one simple clinical application. This is a medical condition called glomerulonephritis. And now that we know the anatomy, it means that there is inflammation in the glomerulus of the nephron. Where exactly? This will occur in the filtration membrane. This is common. It can be due to many different causes. Infection is one of the most common causes, bacterial infections and other infections. What happens with inflammation? Swelling, damage. So there's going to be damage of the filtration membrane. The pores are going to be wider, and now my filtrate is not going to keep in the larger particles. So if my patient comes with fever, urinary symptoms, we have to take a urine sample. And if we look at the urine sample, it's going to be very indicative. We will see that there is hematuria and proteinuria. The red blood cells are now filtered and they appear in the urine. The proteins are not held back and they appear in urine. And of course, we need to go in and treat these patients and give them adequate care. We are done with this part of the presentation. The sequel for this is going to be the other two steps that are important in urine formation. We're going to talk about the tubular reabsorption and the tubular secretion in another lecture. And thank you again for joining us.